Welcome to the April 17th, 2025 PD Parlor with Dr. Priya Cardone, Movement Disorder Specialist, Neurologist of UPMC. She happens to be a local, graduated from Montour High School, and she graciously gives her time and expertise each month. This month, the topic is gait issues, which most likely applies to all of you. There will be time for questions. You can type them in the chat at any time, or toward the end, you can unmute yourself when it is question time. Thank you, Dr. Cardone, and please take it away.
Okay, thanks, Casey.
You're welcome.
All right, so yes, I wanted to do this topic, gait and balance. So gait and balance is a really sort of complicated topic, and that is a very common presenting symptom that patients are being seen by a neurologist for. It's not always the tremor, it's not always already having a suspicion of Parkinson's disease, but typically a very common presenting bothersome issue is issues with balance, falling, and having difficulty walking, because that is the goal of everything we do, is to keep people walking independently and maintaining their mobility to maintain their independence and living at home, hopefully. So when we talk about gait and balance, this is a typical picture of what we look for with a patient who has Parkinson's disease or suspicion for Parkinson's disease. So some of the easy ones are the stooped posture, so we have a hard time standing up straight. We have a forward tilt of the trunk, and there's a specific name for that, which I'll get to whenever a little bit later on. Rigidity means stiffness, so having a loss of flexibility, which will affect your sense of balance and walking. Arm swinging, so arms are supposed to swing out because that's the way our body helps keep balanced upright. So if we have reduced arm swinging, it will impair our sensation of feeling balanced. The next thing that we talk about for gait and balance is the shuffling gait. So that's kind of an obvious one. People already know that they have it if they come in, or their spouse or family member has observed shuffling gait, as well as short steps where you're not quite swinging your legs all the way out to clear the other foot. They're kind of shuffling along right beside each other. Okay, before we talk about Parkinson's disease walking or any other neurological issues with walking, first we should go through what are the components of normal walking. So we'll start with the stance phase, which is the part where your body is more firmly planted on the ground, and then we'll move to the swing phase, which is where your leg is actually moving to get ahead and propelling your body forward. So first we talk about heel strike. So if you are my patient or if you've done any physical therapy for Parkinson's, one of the common things you will hear the physical therapist remind you to do is to walk heel toe. So you should land on the heel, roll your foot forward to the front of the foot. Then the weight will shift over to that front foot, and then the second foot will start to move to kind of catch up to the first foot. So this is the part where you're depending completely on one leg. This is the part where you are dependent on two legs. So you'll feel a little more balanced in this area, but this area where you're depending on one foot contacting the ground can be part of the problem. Then we go back a little bit towards this pre-swing. So when this second leg is getting ready to move, we're back to having two support points and two contact points to the ground. And then the swing phase is where we are really using that other leg to move forward. So that the second leg that's moving is kind of free floating in the air, not touching anything, and it has to get all the way to the front of the body. So you can see here that there are different phases. So there are 2 points where you have 2 feet on the ground, and there are more points where you have only 1 foot on the ground. And the part where you have 1 foot on the ground is the part where you do need to rely on your sense of balance to avoid falling. Okay, so the gait pathway. So when we have someone coming in for abnormal gait, we really have to look at the entire body and decide which parts or which components of the gait pathway are affected that is affecting the patient's ability to walk. So starting up top, we start at the brain. The brain has to be structurally intact without a lot of disease or shrinkage or history of a stroke or injury to be able to generate the messages to tell the rest of the body parts how to move in order to walk. There has to be a cognitive aspect as well. So it's not just a structural issue of the brain. There has to be a function of the brain as well, where you're able to come up with the idea that you need to walk. Next, the brain will come up with all these messages and they have to travel down the spinal cord. So you have to evaluate whether a patient has spinal cord disease, such as arthritis, bulging discs, or any other spinal cord lesions. For example, people with multiple sclerosis may have spinal cord lesions, and that will be impairing their ability to walk and blocking the messages from the brain to the rest of the body. Once the message gets down to the spinal cord, it will travel out of the smaller nerves. So those nerves have to be intact to carry messages from the central part of the nervous system out into the peripheral or side parts of the nervous system to be able to carry out the messages. Nerves will then talk to muscles and tell the muscles to either contract or relax or move or shorten. And those muscles have to be able to receive the input accurately. The muscles then have receptors which are activated that tells the muscles that those receptors are used or are being used or they were used correctly. And those receptors then send feedback back to the brain, back along this pathway again, up the nerves, up the spinal cord, and back into the brain. Sorry, I have my heater on in here because I'm always cold. So feedback back to the brain. And this is a constant loop that occurs billions of times per day on a microsecond level of speed. So it's extremely fast, like lightning. So if any one of these ingredients of walking have impairment, that will lead to gait dysfunction. All right, so first we'll start at the brain. So we need to make sure the structural components of the brain are intact. What can go wrong here? We can have atrophy. Atrophy means shrinkage of the brain. White matter disease, which I'll show you pictures of, is injury to the inside portions of the brain, which is basically all the relay stations where messages are communicating and going back and forth super fast. White matter means these neurons are covered with a fatty layer, which is the insulative layer, which helps the messages travel extremely fast. So if we have injury to this area, it's called white matter disease. And we'll go through common causes of that. If you did not already, you can watch my other video called Cognition, and I'll ask Casey if she can maybe put a link in the comments to that video. Stroke, if you've had a stroke and you have some injury to a portion of the brain, that will affect your ability to walk potentially. Cerebellar atrophy. So the cerebellum is at the back of the brain. It controls coordination of arms, legs, and balance. There are certain conditions that disproportionately cause the cerebellum to shrink down. So one of them is chronic alcohol use. Another one is history of using a medication called phenytoin or Dilantin if a person has had a history of seizures. And there are other forms of shrinkage that are related to having specific types of cancer. So when you have shrinkage of the cerebellum, you can have balance issues with arms, legs, coordination, and truncal stability. And then, of course, Parkinson's disease, which is where there is a reduction of the actual chemicals that are made that are supposed to help you move. There's a reduction of the neurons or brain cells that make these chemicals. And finally, hemorrhages. So little bleeds all over the brain. That's another medical condition called amyloidosis. That can overall contribute to brain injury, and that can contribute to difficulty walking. So let's start by looking at a healthy MRI of a brain. So this is a MRI. It's called the FLAIR sequence. This is kind of the exposure that we use to look at old injuries to the brain. So when you take a picture of a brain with an MRI machine, it gives you a bunch of different exposures. Each exposure tells you a different thing. So one of the exposures shows if a patient has had an acute stroke. This is the exposure that shows us kind of the history of the brain, what has happened to that brain over a lifetime. There's another exposure that shows us if there are areas of bleeding, but this is the most common one that we kind of look at to get a general idea of what has this brain undergone through its lifetime. So it's opposite though. So you have to think of this gray stuff is actually white matter and the outside is actually gray. So it shows up a little bit better on this picture. Again, these are just pictures I kind of had to glean from the internet, but in real life, this inside gray part is actually white because all these fibers are surrounded by a fatty myelin sheath. So it's all white. But yes, we call this the white matter, and the outside is the gray matter. So if you can appreciate on this brain, number one, the size. So this is like the edge of the skull here, and this is the inside of the skull. So as you can tell, this brain has two symmetrical sides. The brain tissue is taking up almost all of the space inside, inside that skull, meaning it's pretty much right flush up against the inside of the skull. That means there's no obvious atrophy. The other way to know that is to look here in the middle. So these two halves of the brain are supposed to sit like flush right up against each other. As you get older or due to other medical conditions, you can have shrinkage. So that space appears a little bit wider, which I'll show you in a few pictures. The other thing to look at are these black slits here. These are called ventricles, which are the normal holes that the brain has, and spinal fluid flows through them. This is about a normal size of how those should be. If you have a lot of shrinkage of the brain tissue, shrinking away from these holes, the holes end up appearing a little bit larger. The next thing to observe is the gray-white matter differentiation. So you can clearly see on this brain there's a pretty good line and a border here between the outside gray matter and the inside white matter. Again, that's a sign of generally healthy brain tissue. All right, so what does it mean when you have white matter? So on this picture, white matter, again, remember, is on the inside here. So when you have white matter disease, it shows up actually as even more confusing, bright white spots, basically. So a lot of patients come to me saying, I had an MRI, there were some white spots on it. What does that mean? So this is what that means. These are tiny little areas of injury. It's basically a little bit of scar tissue. So the way I explain it to patients is maybe this little blip right here, maybe one day one blood vessel or two blood vessels were just under a little extra stress. They either squeezed shut or they had a little bit of like an irritability or a little bit of not good enough blood supply for a couple of minutes or so, and maybe it kind of got injured and leaves behind this little mark. So one or two is not a big deal, but once you get that over and over and over again, it starts to add up, and they all add up together. And once you get one of these little spots, it never goes away. It stays pretty much forever. So you get more and more on top of each other, and that's when we label that as white matter disease. So this is like mild, just a little bit here and there. This is moderate, and this is what we would call severe white matter disease, where it looks like almost half of this brain tissue is kind of this injured appearance. This is an example of cerebral atrophy. Again, another picture of the brain where the brain tissue is kind of fat and juicy and plump, and all these little folds here are kind of full, filling up almost the entire area within the skull. And these little slits are about normal size. That's how much they should be really circulating the spinal fluid. When you have cerebral atrophy or shrinkage of the brain, you can see there's kind of these patchy areas where the brain tissue is not as full, it's not as plump. You can kind of see through it because there's a whole bunch of gaps and spaces. And then you can see these ventricles looking quite large. So if this is the normal size, you can compare how this looks a bit larger. And again, it's because brain tissue, if it shrinks down, the remaining areas between that are the empty spaces will enlarge, and they end up just getting filled up with spinal fluid. So here's another more obvious picture of atrophy. So see how there's just missing pieces. There's like a bunch of gaps, and it's kind of peeling away a little bit from the inside of the skull. So what does this actually mean? When you get something like this, a lot of age-related wear and tear on the brain, white matter disease, it will impair cognition, and it will also impair mobility, because all of the messages that are being generated around the outside that then get shuttled inside, they get reorganized before they go down the spinal cord. Those messages some of them will bounce back, some of them just disappear, some of them get mixed up. They all arrive at different times instead of all going together at one time. And that is a contributing factor to gait abnormality or walking difficulties. All right, then there's the cognitive portion of this. So separate from the structural disease, your brain also has to be functionally intact to understand that you have to walk, to have the motivation and generate the messages to start your body moving. You have to have what we call awareness of the situation or awareness of your surroundings. So you have to be able to see what's around you, register how far or close other items or other objects are within your visual field. A lack of awareness is something called anosognosia. So this means generally like a neglect, or you're just unaware of your surroundings, unaware of that there may be something wrong with your gait and balance, you can have reduced insight into your balance difficulties with this condition. And the front part of the brain, right up here, this is the part that's responsible for executive planning. So typically the frontal lobe can take a little bit more of injury over a lifetime due to risk factors. And when that happens, that's when patients start to have some difficulty initiating their walking and planning how to move their body and planning how to move their body within the environment that it's in and based on items and other people around. Okay, so we are done with brain now. Messages move from brain down to spinal cord. Spinal cord is prone to having basically spine disease, so arthritis, bulging discs. That can all cause some crowding into the area that contains the spinal cord. And if that occurs, it can impair the speed and efficiency of messages that are being transmitted. So one thing I do for many patients with multifactorial gait instability, I do usually have a low threshold for checking an MRI of different parts of their spine based on what we find in the physical exam and also based on their complaints. So if people have low back pain and they haven't had a picture of their brain for some time, I'm more likely to get that to check for any other structural issues that are contributing. The other thing that you can see in the spinal cord is basically lesions. So lesions just means some kind of an injury. You can get that from multiple sclerosis. You can have it after a viral infection. You can have it if you have Guillain-Barré syndrome. So there's lots of different things that can cause lesions. But when we look for lesions and we find them, then we go down the route of what caused that lesion. Nerves. Okay, so we're brain, spinal cord sends messages out through small nerves. So these small nerves usually exit the spinal cord in two groups, one big group in the neck that controls arms, one group in the pelvis region, and that controls legs, bowel, and bladder. So these little nerves are exiting through small holes, and those small holes can get crowded if you have arthritis, and it pinches down on those little nerves, and that can cause pain. And it can cause sensation of weakness because the message again is getting cut off or interrupted from spinal cord out to muscle. So with pictures, imaging, we're looking for pinched nerves in the neck or lower back. We're looking to see if those pinched nerves are causing actual nerve injury or if they're causing pain, which is contributing to difficulty walking. Because if you have low back pain or if you have neck pain, that itself is a contributing factor to abnormal walking. So that needs to be treated prior to being able to walk. Okay, so messages go from spinal cord to the nerves out into the muscles. The muscles are what do the actual work. So muscles can be affected if a patient has been deconditioned, if they have not been walking for a long time, they're not getting enough exercise. The muscles kind of wear down and they break down a little bit because they're not being used and they're not being stimulated. The other condition that could occur here is something in the neuromuscular department. So if there's a different disease process that's ongoing where the muscles themselves have something inherently wrong with them, or there is a issue or a disease process at the point where the nerve talks to the muscle, that can impair muscle contraction and that can contribute to difficulty with walking and balance issues. So then muscles get their messages, they do what they're supposed to, hopefully. Muscles and skin contain receptors. Receptors are nerves, basically. So there's nerves out in the edges of the body that are recording what happens and then sending that feedback back to the inside spinal cord, back up to the brain to tell the brain what the body actually did. So did the body part follow the command? Did it not follow the command? Did it not get the command? Did it get some of the command? So here is where neuropathy plays a role. So neuropathy means nerve damage, and neuropathy is likely widely underdiagnosed because if a patient doesn't feel anything, they don't tell anyone. And then even if they do feel something, it can be checked for by a test, a nerve test, but it does not always pick up neuropathy if the neuropathy is not severe enough. And there are also two different forms of neuropathy. So there's the kind that affects large nerve fibers, which is the common kind of nerve test that anybody usually like PCPs or other like general neurologists can order. And then there's small fiber neuropathy, and that is not picked up on the large nerve fiber test. And it's a special test probably would only be ordered by a neurologist or somebody really looking for a suspicion of small fiber neuropathy. So that can cause pain, numbness, tingling, pins and needles, but you get a nerve test and the nerve test is normal. And we think, oh, you don't have neuropathy, but that's not true. You may actually still have neuropathy that either was not checked for because the test did not look for those specific types of nerve injuries, or it was not bad enough that it was picked up on the test. And it depends on who is performing the test. But when you have neuropathy or loss of sensation in feet and legs, that causes difficulty with balance and proprioception. Proprioception is the body's ability to know where all of its body parts are, even if the eyes and the brain cannot see that body part. So, for example, if you stand up and close your eyes, you should still know, like, where's my head, where are my arms, where's my abdomen, where's my legs. Like, you should still know where they are in relation to your brain. And if you have severe neuropathy, that sensation can be lost, and that can contribute to difficulty with balance, because when you walk, we're not all staring at our feet while we walk. We're looking up and we're looking around and we're moving our head and our arms all at the same time. That's because the body's automatically supposed to be able to tell the brain where it is in space. Okay, some other random little tidbits for Parkinsonism. So we can have some abnormal postures, and that can contribute to balance issues. So anterocollis means head drop. Antero means front. Collis means the dropping of the head. So that's a symptom that can be seen in Parkinson's disease, but a lot of other neurological conditions. The other one is called Pisa sign, like the Leaning Tower of Pisa. So it's when a patient thinks that they're sitting upright, but they're actually leaning. And usually at some point the patient is aware that they're leaning, but they have a very hard time correcting that. And it's just an automatic sensation of wanting to lean to one side. Camptocormia is a sensation of bending forward and having a lot of difficulty standing up straight. And the funny thing about camptocormia is when you sit down or lay down, it just goes away and you lay down flat, and you sit down and you're not stooped forward, but it's only when you stand up that you tend to want to bend forward at the waist. All right, another major contributing factor to multifactorial gait instability is orthopedic issues. So at the age group of patients who have Parkinson's disease, you are also in the age group of having things like arthritis, high chance of having had surgical replacement or surgical correction of any arthritis issues in hips, knees, ankles, feet, neck, low back. So anytime you start having these arthritis type of issues or orthopedic injuries, that's another risk factor for your gait to be off balance because of either pain or leftover nerve injury from the injury itself or from the surgical correction of that injury. So that's something that I usually screen for if somebody's coming in for difficulty with walking. And then finally, podiatric issues, so actual feet problems like bunions, calluses, hammer toes, ulcers, all of those are issues. If your feet hurt or they are deformed or you have some type of arthritic condition that you can't really stand on your feet, then that will very easily contribute itself to gait abnormalities. All right, so here are some pictures. This is anterocollis, where the neck is flexed forward. This is the Pisa sign, when it's a little bit more, usually more obvious when patients are sitting, but it can be when you're standing as well. We're leaning to one side. And finally, this is camptocormia, where we're just bent forward at the waist. So when I see this, I always make sure to find out, is there an orthopedic component such as lumbar spine disease? So I always get an MRI of the lumbar spine for camptocormia to check if there is actual structural issue, and if not, then it's solely camptocormia. In most cases, it's a combination of both. Same for over here. If someone's head is flexed forward, I always get a picture of the MRI of a cervical spine, again, looking for structural disease that either contributed to the position or has resulted from the position to determine if that patient needs to have surgical evaluations or not. Okay, so how do we help then? Once we figure out all the ingredients, we label all of the parts of the brain and spinal cord that could have a contributing factor to abnormal gait, what do we do to help? So again, we do combination of medication and physical therapy. So the medications, as I've discussed in other lectures, carbidopa, levodopa, helps to replace some of the dopamine that the brain is no longer making. Amantadine is a funny one. It's a very, very old antiviral flu medication that ended up being discovered to be helpful for walking for neurological conditions. So it's used in the movement disorders world when we use that to help a little bit with walking. It helps kind of more specifically to reduce stiffness if there's one-sided stiffness and rigidity, and it can help with walking. It's also used for patients who have multiple sclerosis to help with their walking speed. There are a couple of other medications. These are the adjunct medications. One is called safinamide or Xadago, meaning it helps you go. So it can help with walking. Norians is another one. It's, again, completely kind of a new category of medications. It can vaguely help with walking depending on what are all the reasons contributing to abnormal walking. And then the real key here is physical therapy. So if we have brain atrophy, if we have white matter disease, how I explain it to patients is that we are no longer able to completely depend on the brain to tell the body how to walk. So we have to kind of go from the other end by telling the muscles how to generate their own movements to walk. So if brain isn't sending sending commands to muscles, we have to train the muscles with muscle memory. So the muscles can be trained to just automatically walk or do something automatically without waiting for that message from the brain. Though that's what we try to accomplish with the physical therapy. It's sort of a motor retraining of the body to help compensate for a lack of central input in walking and using external cues or external environment to help generate messages to the muscles to tell them how to walk. So more than just walking to try to continue walking, there are some specific exercises that can help a little bit more tailored to the balance issues. So we're looking here for any activities that are dependent on the brain to generate specific signals to tell the body to move in a controlled manner. So yoga, tai chi, dance, boxing, ping pong, and pickleball are all really good because you really have to generate messages, channel those messages to the muscles, but then control the muscle movement. So it's not just walking where you're automatically just moving arms and legs. It's a very controlled movement to do the movement, stop when you're supposed to stop, and then do the next movement. If a patient also has the difficulty walking, I'm always in favor of using assistive devices such as a cane, walker, rollator, and even the weighted backpack can sometimes be helpful for the patients who have this camptocormia. It can help to provide a little bit of stimulation and a little bit of leverage by putting some weight down here to help pull the body backwards a little bit and help the posture be a little bit more straight. People are always worried, what if I start using a cane and then I depend on it? You have to be careful of that, but I would rather you depend on a cane and walk around rather than not depend on it and be fearful of walking and then stay seated all day, because that will only lead to worsening of your gait dysfunction. How can a caregiver help? So this is a very common complaint that I hear. So my husband won't use his walker. He just never uses it. He just gets up and goes and then he falls. So in these situations, we have to be very, very understanding. We have to remember that that person's brain may not recognize that it needs help with walking. That's where the anosognosia comes in, the lack of insight. It may not remember also that it needs help. It may not even, it just may not remember that you reminded them to use the walker. So it has to be a kind of a reassurance, redirection, a lot of gentle reminders, a lot of cueing to say, remember the walker's here, remember the cane is here, remember the walker is here. And we have to just be very, very patient. So I try to very much counsel spouses who are getting frustrated with their spouse that they're not using their device. Their brain may not recognize that it needs a device, and then even if it does, it might not remember to use the device. So we just tried to remind gently. So one of the other things I forgot to say, the physical therapy. So back in the slide where I talked about the cognitive aspect of walking, falling is a huge deal. So falls not only can cause structural issue or physical injury to a patient, they do a lot more emotional and cognitive damage, I have found. So once a patient falls once, it gets in your head. People become scared of falling, and there are times when that fear of falling is stronger than the risk of falling itself, and that fear of falling masks everything. So the only way to get rid of that fear, that's really where the physical therapy comes into play. So it's not only the motor retraining that we're doing in the physical therapy, it's the cognitive aspect of sending a patient to physical therapy. The patient has a social visit out of that, meaning they have to leave their house, they have to get dressed, they have to go talk to another adult that's not their spouse or that's not their family member. They have to interact with that person, they have to perform these exercises. And then once you complete your session, there's also a sense of accomplishment and some sense of self-confidence that returns after completing that physical therapy prescription or routine. So that's another major perk of the physical therapy. It's not just a physical thing that I'm trying to do there, it's a cognitive aspect of walking. So once some of that self-confidence comes back, then the patient is also left with a specific regimen that they may continue to practice on their own. And that's another time where the spouse can get a little frustrated and say, oh, he doesn't want to do it, he won't do it, she won't do it. Again, we have to go back to the underlying reason. Why are we not doing it? Is it because there is pain? If there's pain, we have to treat pain. Are we not doing it because there is a lack of motivation or anhedonia that can be a sign of depression? So does that need to be treated? Is there physical barriers, like we are, the house or the location is not easy to access or is not conducive to continuing physical therapy? So there's other reasons. So we, again, always are trying to look for underlying reasons of why things are happening or not happening, and then treat that reason to allow a patient to be able to do their exercises or do their treatment as prescribed. Okay, so that's kind of all I have for today. So I can open up for questions.
Okay. Let's see. Oh, Dr. Cardone, I think you need to stop your screen sharing altogether, if you don't mind.
Okay.
There we go. Okay, everybody. What questions do you have? You're welcome to unmute yourself and ask the question or type. Dr. Cardone, how does an occupational therapist assist with gait issues?
So occupational therapy, so we can, that might be an area where if a patient is having difficulty with gait because they can't see or hear, it can be as simple as like training or reminding that patient to keep their glasses handy or keep those things accessible. They may also be helpful a little bit if patients have issues with their hands due to hand weakness or stiffness and they have a hard time using a cane or walker. Might be helpful to be creative with an occupational therapist to come up with devices that would allow a patient to use an assistive device in spite of having hand weakness or fine motor skill weakness. I think that's what I can think of for that.
Thank you. It looks like a question came in. With some medications causing sedation, what do you suggest?
Oh, that's a tough one. So yeah, we always have to weigh the risks versus benefits of medication. So medication, you should try to be getting more benefit rather than side effect. So if your side effect is sedation, then you can consider, can that medication be given at bedtime so that if you're going to get the side effect right away, like right after you take it, you're going to be asleep anyway, or reducing the dose or splitting up the dose into 2 different times or multiple times in the day. But the other important thing is we should not always blame medication for fatigue. So if we have fatigue, again, we have to make sure there's no other underlying cause that is already making a patient tired, and then you give them a medicine and they get a little bit more tired, and that's what they blame the tired on that medication. But was there underlying sleep apnea that you already had making you tired that a medication worsened? Is there underlying B12 or iron deficiency that was already making you tired to begin with, and then you got a little more tired with medicine? Is there depression or anxiety? Depression, which can cause fatigue if it's not treated. And is that really the underlying cause before we blame it all on medication?
Thank you. How can DBS surgery help with walking and balance?
Okay, this is a complicated question. So DBS surgery will not make you suddenly on balance. It will not remove your balance issue inherently and directly. How can it help with balance? It can help if you have stiffness or rigidity on one side of the body a little bit more than the other, and that side is not moving as well, causing you to be off balance. So it can help with that. If you are off balance because you're walking so slow that you don't have that momentum to move forward, that can help with increasing speed. If you're off balance because your legs are moving at one speed and the rest of your body is moving at another speed and they're not matching up and you're tripping over your feet or your feet are running to keep up with your body, that's a place where the DBS can be used to help keep everything on the same speed within the body. So it's an indirect way of helping, but not a direct way of making you feel suddenly balanced. Because remember, I talked about all of those ingredients that go into balance. The primary one of which is brain injury. So if you have a lot of brain injury, white matter disease, shrinkage, strokes, those will all affect your balance, and the DBS will not be able to change any of those issues. Okay.
Oops, thanks. Would you like me to? I can read the question.
Yeah.
I was by myself. My own. Please discuss various theories about patients who have the type of Parkinson's with primary gait issues versus primarily tremor issues. For example, I heard gait patients have worse progression and life expectancy.
Okay, so yeah, this is a tough question again. Since everybody's Parkinson's disease is so different, generally, yes, we kind of put people into two categories: people who started with tremor predominant or people who started with bradykinesia, stiffness, rigidity prominent. And you're right, the stiffness and rigidity is harder to treat in the beginning, and those patients have a little bit harder of a time. Because the reduced gait and mobility are what affect your ability to stay like independent, whereas the tremor really doesn't affect your daily life as much. You can, if you're still walking and you're moving at a normal speed. So I'm not sure if I can say much about like progression and life expectancy. Again, that all depends on how early were they diagnosed, how early and aggressively were they treated, how were they evaluated for any other conditions that are contributing to their symptoms, and if all of those things were addressed optimally or not, which they frequently are not. So I guess it just depends on when were you diagnosed and what other issues you have contributing and how were you treated.
Thank you. We'll allow a few minutes for additional questions. Dr. Cardone, how do you typically address freezing of gait?
Freezing of gait is tough. That's another like really annoying little problem that happens. So freezing of gait is when a patient stands up and they try to initiate their gait. Their feet are stuck, frozen, planted to the floor. They don't want to move. It can also occur while walking. You can have freezing and you're suddenly stuck with feet on the floor. And the other common time when it occurs is when a patient is transitioning from one room to another and they have to suddenly go through like a narrow doorway or they have to cross the threshold. And the brain becomes like suddenly overwhelmed or overstimulated by that. It's like a sudden getting smaller issue, and that can contribute to freezing. So a couple of things for that. One, making sure medications are optimally dosed and timed. So if we have a lot of freezing at the end of a dose period and we have to wait until the next dose to kick in until that freezing goes away, that tells us we either need to increase each dose or move those doses close together, or add a medication to boost and increase the length of each dose to reduce that wearing off effect, which is for that patient, it's freezing. The other things that can be helpful, so the two of the medications, the Norians and the Xadago, are supposed to be helpful for freezing, again, within this large complicated clinical picture. So sometimes I add those medications, although I do have a lot of trouble with insurance, and the Norians is quite expensive, so I hardly ever get to actually use that. The next thing that can be done is when you're in physical therapy, there can be a specific signal that a patient and a therapist can come up with together, such as marching to a certain song, marching to a certain beat, making a certain sound that tells their body, gives their muscles a different cue, not dependent on the brain, but gives their muscles a different cue to walk. So one of the things I really like, again, cost dependent, unfortunately, is the U-step walker. It can come with an attachment that's either a laser or a clicking sound, and sometimes shooting that laser on the floor gives patient's brain like a visual cue of something to step over. So that tiny little cue is enough to tell their brain, okay, it's time to pick up your foot, put it over that line. And you do that over and over until the freezing, you pass through that freezing. The other thing it comes with is like that clicker. So it's just a little device that says like click, 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 and that's a audio stimuli to start walking. So once in a while, from time to time, I go on Amazon and I search. There are all these devices that you can purchase separately and add onto a walker. So that's something I have suggested to patients because it's a lot less expensive than investing in that one specific brand of walker. And that way it's also portable, so you can take it around with you.
Thank you. There's also something called neck stride that you can actually attach to a walker that has the metronome and the laser.
Oh yeah, metronome. I couldn't think of that word.
No, I always have trouble with that one.
Oh, can you put the link to that actually?
Yes.
That would be, I did not know that brand specific. Okay.
Go ahead.
Yeah. What about people with Parkinson's disease who have spatial issues or misjudged distances? So yes. So the patients who have that frontotemporal shrinkage or injury of the brain, the front part of the brain is the part that calculates visual spatial issues. So yes, that is a very common issue. So again, using different forms of cueing and basically physical therapy. And again, if there are major cognitive issues, that would be something that I address with formal cognitive testing. And if it's at the point where it's bothersome enough that a patient is having such cognitive issues that are interfering with their walking, that might be the point where we would introduce a medication to help with improving cognition and observe if that translates over to improved visuospatial perception. Facial masking just means like the masked faces that people with Parkinson's disease have. It's reduced facial expressions, not blinking your eyes as much, the mouth sometimes being parted, and just like reduction of your facial expressions. Sorry, I'm sitting on a donut pillow because I'm also having my own back pain issues today. Okay.
Let's see. Dr. Cardone, how do you address your back issues?
Yeah, right. I try not to pick up my kids, but that's impossible. Probably need to do some stretching myself.
There you go. How do you feel about tests that can, there was the one that just came out by Israeli scientists, a possible blood test to detect early Parkinson's, just regarding like the earlier diagnosis and how that may affect the progression, especially gait issues, since you're talking about that today.
Mm-hmm. I don't know. I think I saw it briefly, but I didn't really delve too much. I don't know. I'm not really a fan of like going looking for things that don't exist yet, because if you get that test and it's positive, how are you going to change your life? Are you going to just like commit to like not doing anything because you're going to develop Parkinson's? Like, yeah, I don't like to put things in people's heads that doesn't exist. So I actually tell my patients, like, try not to read too much stuff on the internet. Whatever you need to know, like, I'll tell you here, and that's why we meet frequently. But the more, sometimes too much information is not as helpful as just kind of just minding your own business, kind of like just worry about what you have and what I tell you and what you tell me here. And sometimes if patients don't know, I actually have a questionnaire that all my patients get at the beginning of their visit with about 20 yes or no questions. That's based on like the Parkinson's like treatment guidelines. So it's those 20 symptoms. So when I get that, I scroll through quickly, I scan that, and we talk about the pertinent positives. And that's usually like enough.
Thank you for sharing that.
You're welcome.
It is true that there's so much out there, and it can be overwhelming, and you develop your PD care team and take those steps and try to limit too much information.
Yeah.
Any final questions, friends?
Does the guide you talk about focus on non-motor? Yeah. So let me see if I have one. I won't show you the name, but I have one. So it's divided into, you can't see that. I'll just tell you, mood and cognition, autonomic or digestive symptoms, so things the body does automatically, like blood pressure regulation, constipation, swallowing, exercise, so if you've had any falls or had physical therapy recently, and sleep. So those are the ones I ask the patient to tell me about before I start the visit so I can scan, and then more specific details about like medications and on and off, we talk about that verbally. So yes, it is motor and non-motor symptoms, which is should kind of encompass all of the body parts that are affected.
Any other questions? This was very helpful as always, Dr. Cardone.
Thank you. Thanks so much for hosting. I appreciate it.
You're welcome. And stay tuned about the May PD Parlor. We'll let you know if it's on. There's a possibility that we might not have it in May, but keep an eye out for emails. Thank you, Dr. Cardone. Thank you, everyone, for joining today.
Thank you so much. Thanks, Casey.
Welcome. Bye, everybody.
Bye-bye.